topic allotted is very vast. I hope next 10 minutes I will try to convince what I do in such, a vast topic. Early osteoarthritis, UKR, HTO, or a TK. Does it really matters? As you know, it's the second only to the heart disease which is causing a disability. Almost 1.5 million people are suffering from early osteoarthritis or osteoarthritis at present by the WHO data. And this data, this number are going to be double. So all young budding orthopedic surgeon has a very bright future ahead. Again, the more and more younger population is affecting. The previously, before 2014, the affection age was above 65 years, but now it is less than 50 years. Again, the females are, the dominating in this. So to define the early stage knee osteoarthritis, it was defined in a conference held in 2014 in Tokyo. And it requires presence of two mandatory symptoms. One, the knee pain in absence of recent trauma or any injury or fall, with a short joint stiffness less than 10 minutes, or two, knee pain with one or two risk factors or three or four risk factors with one mandatory symptom which is lasting for less than 6 months. They have excluded the inflammatory arthritis from the definition of early stage knee osteoarthritis. Again, they have defined that early onset of osteoarthritis, the age criteria is 50 years or less. Coming to the treatment part, I hope everyone is trying these modalities, and we will discuss, in the last session, medications, lifestyle changes, supportive devices, and the complementary therapies like physiotherapy, yoga, and hydrotherapies. Coming to the surgical treatment, I'm excluding the arthroscopic surgeries in this, and we are concentrating on the replacement and the HTO and the total TKs. Real dilemma is when we face such patient X-rays, radiological picture with early age, like in the early 40s to 60s years of age, what to do and when to do. Coming to the HTO and UKR, HTO and UKR are a strange couple. They serve the purpose of treating the anteromedial osteoarthritis. They have different philosophies, but they are aimed at treating the AMO, that is anteromedial osteoarthritis. Coming to the indications of the HTO, it's a correction of the knee angular deformity, especially the metaphyseal varus. It is done for the young physiologically active patients. You can correct up to 15 degrees of varus. One has to, the other ligaments and the other compartment has to be normal to undergo the HTO. Again, obesity, BMI is a debatable issue. HTO can be associated with the other procedure like arthroscopic surgeons are doing for the cartilage resurfacing, meniscal transplant, any ligamentary reconstruction, posterolateral laxity, and etc. Looking at the contraindications, severe degenerative changes even in the medial compartment is considered as a contraindication for the HTO. Definitely arthritis in other compartments is big contraindication. The age above 65 years, one should avoid doing an HTO with the risk of failure increases almost by 8%. And as compared to the less than 65, it is almost 1.5%. Again, BMI is debatable. So what I do, some cases which I had a difficult time taking decision. 50 years old lady, very active. She works in a farm and runs a business. Another orthopedic surgeon has only done an arthroscopic surgery for the medial meniscus, but he has forgotten the varus in the tibia, varus in the knee, leg, and he has just considered the arthroscopic surgery. Patient was not happy. Even after 2 months of the surgery, she was complaining of pain, swelling, and walking with the walker. The ESR and the inflammatory markers were a bit on the higher side. The option was to again do the partial knee replacement, or because of the inflammatory markers, we have decided to do the HTO with an arthroscopy, and it is immediate post-op, and after 1 year, patient is doing good. Another case, a very active offshore working gentleman, 52 years old. He was doing good, but one day he hasn't fallen and torn his root, medial meniscus posterior root. And on X-ray, he was having anteromedial osteoarthritis, but he was not symptomatic. We had advised him UKR, but patient was not ready to accept the uh, funda of replacement in his joint, as he was physiologically very active. Again, we have done the arthroscopy, root repair, and the high table osteotomy. Again, immediate post-op and after 1 year of post-op. Another case, somewhere done the meniscal injury, treated with the arthroscopy somewhere in the interior of Maharashtra. Again, patient was not happy even after 6 months of the surgery. Injections and all the things were done. Patient has developed a periarticular osteopenia. Some people have advised him to wait for a few more years and consider a total knee replacement in 48 years of age. Again, we have done the arthroscopic plus the HTO, and this is after 2 years, patient is doing good. Coming to the UKR, partial knee replacement or unicompartmental knee replacement, again, less commonly performed, but the interest is growing in the orthopedic faculties. As now every company has come up with their own implants and instrumentation. Few years back, that was not the case. Only 1 or 2 companies having the instrumentation and the implants available. It has very good data of 20 plus survival years. Some call it as a partial uni, microplasty, or UKR. You can type them, or you can classify them according to their designs, like uni, that is fixed bearing, mobile bearing, that is Oxford knee, all polytibia uni, and monologue, that is Slade prosthesis. So why partial knee? It's an ideal surgery for anteromedial osteoarthritis or early osteoarthritis, because it is a preservative surgery, and at the same time it's a prevention surgery. So we actually come across almost 25 to 30% of the patients in any joint replacement surgeons OPD. They are examining at least at 30% patients there is an incidence of anteromedial osteoarthritis. So that actually means 1 in 4 patients, if you are doing a total knee, then these patients are a candidate for the anteromedial osteoarthritis. Looking in the literature, UKR designer series, a 10-year survival is almost 98% for the anteromedial osteoarthritis. If you go and search for the independent series for the UKR, the data is almost 15-year survival is 94%, and subsequently they followed for another 5 to 10 years, and the survivor is 92%. So that itself indicates that it's not a time-buying surgery, so it's a permanent surgery. You can advise that as a permanent surgery. Again, if you go see the design-wise or the implant-wise literature search, a mobile-bearing device, implants, long-term results shows really good 95 to 98% of survivorship after 10 years. Fixed bearing designs, they have an upgrowing curve in the success after 10 years of surgeries, and nowadays they are giving the good results. Newer Oxford data suggests the UKR patients are 2.7 times more satisfied than the total knee replacement, and they have felt 1.8 times like a natural knee after the knee replacement surgery. Looking at the indications, the Oxford called it as a criteria. So that means anteromedial osteoarthritis, that nothing means you had an intact ACL. That itself means that your other cartilage or lateral cartilage is full and intact. The varus has to be correctable one, and the FFD has to be less than 10 to 15 degrees. Again, these are the not contraindications, like patellofemoral pain, activity levels, age, and obesity. Cousin and Scott has gone ahead and defined a term called as these are the accepted contraindications for the partial. And he has shown for the patellofemoral pain, they published data of almost 1,700 patients, 65 revisions were done, but none was done for the patellofemoral pain. Another scar, almost 700 Oxford knees, 50 revisions were done, and only 1 was done for the patellofemoral pain. Looking at the age, the more the old patient, unfit or relatively unfit patient for the surgery, TKR. So UKR becomes an ideally because it's a minimally invasive, low morbidity, and the survivorship of greater than 60 and less than 60 is almost equal for a UKR. Obesity, there is no increased wear by Organising shown in 1992, and even in the morbidly patients, they showed a good short-term results. How do you diagnose? You have to have a good quality lateral X-ray with a condyle overlapping. Keys, has shown that lateral X-ray is more than enough to diagnose the intactness of the ACL, and it shows 95% of the predictive value. I think this will help you to diagnose, take a decision for the indications. Like UKR, more than 55 years, and H2O less than 65 years. Low demands activity, you should advise a UKR. Again, very active patient, H2O is a good option. VMI is a debatable issue. Again, ligament has to be intact for orth, but you can, to the H2O, you can forgive up to the grade 2 of ligament laxity. Arthritis, again, any stage of arthritis, you can take in a TKR in a medial compartment. But H2O, you have to have one to two stage of the arthritis. I can add to MRI findings, like whenever there is an acute cartilage injury or acute meniscal injury, you can choose for the H2O, but not for the UKR. So when to do it, you have to choose the right patient, that you have to diagnose it right. Understanding the instrumentation system, whatever the company which you are using, one has to do instructional courses to really gain mastery in doing UKRs or even the H2Os. Keeping TKR set available is mandatory, and one has to understand there is a learning curve to do the partial knee replacements. Yeah, this was the first few cases, almost 12 or 13 years back, when there was a phase 2 of a mobile bearing, that is Oxford. The instrumentation were very clumsy and very difficult to understand. But the design was itself was forgiving, and this X-ray is even after the 13 years of follow-up, I think. 2011 we have done it, and the patient is still doing good. As the instrumentation increases, as the surgeon starts doing, my also experience increases. When the microplasty instrumentation came, mobile bearing, I started hitting the targets, on regular basis. Another tricky patients, bilateral patients with the right knee anteromedial osteoarthritis, left knee patient has an history of fall and developed chronic ACL deficiency. So we have gone ahead and performed the right UKR on the right side and total knee replacement on the other side. And the patient's age is almost, I think, only 52 years. New trend, I think that this is a game changer in the UKR, a robotic assisted uni replacement surgeries. This really gives you confidence and the precision, the accuracy of the surgery. What you get, you had and balancing in the extension, balancing in the flexion. You had and always control what you are cutting, how much you are cutting, and you can do the balancing before cutting with all the values in front of you. You know how much of virus you are getting in the end, how much of the flexion extension you are getting. This is the help with the help of, and believe me, with every time you get the same results with the partial knee replacement. Once एक बार ऐसा आ जाता है कि you have to started doubting your X-ray radiology picture. Either they are giving the same picture for every patient, but every patient, every time you get the same picture when you take a help of robotics while doing UKR. I was quite lucky to do some lateral unicompartmental knee replacement. Why I do it? I get these kind of results. Free flexion immediately after the surgery. Again, this is a free flexion within 1 to 2 months. Patient start doing it. Another patient, a bit extended, I can call as an indication to do a surgery. Only 50 years old lady, housewife with a lateral thrust. Ideally, it's not an indication for a surgery, but we had gone ahead and done a partial knee. Patient was doing good. This is 15-20 days before, and within 2 months, patient has come for the right partial knee replacement. Patient demanded the another knee because he was developing a thirst on the other side. To conclude, if you look at the systemic reviews to compare the UKR and the H2O, there was almost 3,000 patients were studied for the comparison and complications for the H2O group, and they concluded that a UKR is superior to the H2O in minimizing the complication and enhancing the post-operative functional score, but they have considered only the mobile bearing designs when comparison. Another study, a systemic review and meta-analysis, which shows open wedge H2O resulted in lower revision rate to the TKA as compared to the UKR. Whereas closing wedge osteotomy has resulted in a higher rate of revisions of UKR to the TKA. Another study by the Cartman and Walls, it's a retrospective 20 to 40 months follow-up. He suggested that H2O showed 100% survival in first 2 years, where UK is only 91% in the first 3 years. But if you go for the, look at for the long, good and excellent results long term, only the 57% shown in the STO group and the UK group remains unchanged. So they concluded that the UK is a valid alternative to the TKA. Another paper which also shows that, STO in terms of functional results and pain, the UKR is a good option over the STO. Again, to conclude, both UK and STO are show satisfactory results and the long-term in follow-up. Revision of UK or STO to the TK is a big debatable issue. You had and faced problems in while revising STO in taking surgical exposure, and especially the tibial component positioning is a bit challenge. But again, this can be solved with the robotics nowadays. UK, again, you had a bone stock management problem on both the tibial and the femoral side. Total knee replacement in early osteoarthritis is definitely not an option nowadays. Those who are doing UKR is a good options. I'm just run through the literature, last 2 slides. Unicompartmental knee replacement, the patients, 23 patients were undergone UKR and TKR in same patients. They have good range of motion in UKR patients as compared to the TKR, and the 44% preferred UKR side than the TKR side. 81, another study, 81 UKR versus 120 blood transfusion is only 1% in UKR, whereas say 70% in TKR. Another study, UKR requires shorter hospitalization stay. And Swedish knee registry suggests that risk of infection is only 0.8% in the UKR as compared to the total knee replacement. Thank you.